All right, welcome back to another Owens Recovery Science podcast. Johnny Owens with the bearded wonder, but he wish it was up yonder. Kyle Kimbrell, up yonder, man. You know, you wish you had some up top.
Up yonder way.
Anyways, my man,
On my
I
face.
think you get it. So, Kyle, what's up, man?
Took me a minute. I had to think about that one.
Yeah. Well, you're already
Oh,
drinking beer.
already drinking beer. And I just wanted to be loose and ready to have a good time talking to our guest about BFR and whatever else we
Kyle,
talk about.
do you recognize these?
Hey, where'd you get those, Johnny?
Yeah, they came in the mail while I was out of
What
town.
are those for the people that aren't watching on
And
YouTube?
my wife texts me, they're rabbit's feet. And my wife texts me while I'm in New Orleans working, and she said, "Did you order rabbit's feet from Amazon?" And I said, "What the hell are you talking about?" It took me a minute. So you guys should listen back to the amazing podcast we did with Dr. Sherry Johnson, who's doing very cool stuff research-wise with equine therapy. And blood flow restriction, and we're going to learn so much from her. But apparently, I went down a rabbit foot wormhole with her, and these guys sent me rabbit's feet. I didn't think you could get them anymore, so now I got a bunch. But what happened is
rabbit's feet on Amazon.
my daughters wigged out because they've never seen anything like this, and so they touched it and felt the nails, and they had a heart attack. But so you sent me 4, but
Is that all I sent you?
yeah, but I have 3. I put one on my youngest daughter's backpack with all her little bows and things like that, and she still doesn't know that it's on there because she was like almost throwing up when I have it. So yeah,
amazing.
So it lives on. So thank you for that, man. So anyways, thank you for joining our podcast. Thank you for joining our podcast. We never say this, but I think we're supposed to start saying it. Please like and subscribe. Give us some
channels.
likes, man. All the channels. It really helps us. We never ask for these things, but I think we should do this. And so we just dropped another podcast with Dr. Annie Bain on blood flow restriction and Parkinson's, and a study she put out there, which I think is freaking groundbreaking. I said this on the podcast. I feel like it's a study where we could potentially go after Medicare code, maybe get FDA approval for it, for what it can do for the vascular system. So Annie's amazing. She does great work. We need her to do a lot more work and get some multi-center trials so I can go after the FDA on this. But check out our other feeds. But today, man, I got my brother from the Big Apple, the big NYC.
That's a nice introduction already. That I can't.
I met him 2017. We hung out up there at Hospital for Special Surgery, HSS. And so I worked up there. We did a course together, and Snay and I out of all the group, man, you're the one I talk to all the time. And so it's pretty awesome to have you on today, man. I'm gonna maybe do your bio in a minute, but first off, welcome, Snay Patel.
Thank you. Listen, happy to be here. I'm happy that when you guys wrote to me a couple weeks ago, like, "Hey, Snay, we'd like to have you on the podcast." I'm like, I'm down. Like, I'm totally down with that. Nice. So yeah, happy to be here. And so thanks to both of you.
Let me do it. Well, first, why does everyone from HSS have like the coolest, sexiest voices?
Oh, is that
Snay has it? Who's the other guy that did the intro?
Brian.
Brian who?
Oh, not Gorman. I'm blanking on his last name. How can I blank on Brian's last name? I love the guy.
Luke Hughes is Drake, and I'm Jay-Z.
Stand by. I can't believe I'm blanking on
this is the best thing for a podcast, man. Is
weird, awkward.
We do
Goonan.
Oh, Brian Goonan. Yes.
Goonan, man. Yeah. So anyways, you guys got like voices made for podcasts. I can't say anything about your face, but it's all right, man.
Ooh, so that's good. That's good though.
I can't say anything, but
I like fresh.
Yeah, he's like, I will say something about your face though. So I got it.
But
every time Johnny insults the guest, I have to take a drink, Snake.
Oh, hey, listen,
you're gonna be drunk.
When we got on here, I was like, wow, Kyle already started. Like, this is impressive.
Yeah. And he's West Coast. It's like 3:00 in the afternoon.
Yeah. Great.
But here's what's going to be really amazing with this podcast is that, like when we had Heather from Elite Ortho out in LA, who works like at tip of the spear with the top end surgeries that Curlin Job is doing with super high end or just your weekend warrior or anyone else, her perspective where she's doing BFR like nonstop all day, and we learn so much from her. Snay's the same. And so he's at HSS up in New York, which is one of the leading institutions there is for orthopedic surgery out there. People, they kind of pride themselves if they've gone through that fellowship there. So he sees the best of the best from the surgical perspective and from the patient perspective and how they apply it from rehab. So let me just get in his bio real quick. I didn't really know you were this old, brother. 23 years of experience. So
It is.
like
It's
2001, you're like me.
Yep.
Yeah.
Yep. It's been a
Yeah.
long time, long time. So
I'm
I'm the old
98,
head.
man. So I
I'm
hear you.
the old head in the clinic. So it's they let me know it too. So which is fine.
Me too. Me too. So right now he's the clinical coordinator of HSS Westside Sports Medicine up in New York City, and he really focuses. So it's kind of a lot of lower extremity things: ACL, knee cartilage, hip arthroscopy, for the surgical patients up there at HSS. And if you know anything about that place, you're going to see a lot of pro athletes. So he sees everyone from NBA, WNBA, NFL, NHL, MLB, MLS, as well as all these international athletes. He's a lecturer, he's a researcher, he's published, he's doing BFR research and publication as well. And he's also the director of the HSS Brooklyn Nets Lower Extremity Fellowship, which is pretty cool. I'd like to hear about that.
Yeah,
So,
yeah. Just started that
Snay,
this year.
my
So yeah.
man,
Thank you. Thank
welcome.
you. That's a nice introduction. Again, listen, we've talked a lot, I think since really the inception of BFR being, kind of coming onto the mainstream. So this is kind of like a full circle thing for us where we started off very much in its infancy and now we're at the point where it's like we're using it like in our practice we use it on an everyday basis. It's kind of if it's not there, we have a huge issue in our clinic.
Yeah. So let me just tell you my first experience with HSS. So I was a DOD guy, mostly ortho trauma, hadn't worked a lot with the HSSs or the Curl and Job type places of the world. And so I am presenting the first case that we did in NFL with BFR at the NFL Combine. And I get done, and it's, we really made sure we rolled it out right and like, da da da, and this is the best thing you've ever seen. And when I get done, all these orthopedic surgeons come up afterwards to come talk to me and trying to see if I can come work with their teams and things like that, right? And they're all talking to me. It's like, all these guys, and all of a sudden, like the waters part, like Jesus is walking in, and there's this older gentleman that starts walking out. Like, who the fuck is this
Yeah,
motherfucker? Right?
yeah.
He's coming in. I'm starting to get nervous because they're all looking at him, and it's Russ Warren. And so he walks up and he says, "This sounds like one of the most amazing things I've heard in the rehab space in a long time." And he didn't have a card. He said, "I want you to contact me." And so he made me write down his number and said, "I want you to come work with the New York Giants as soon as you can." And so HSS and Russ Warren were one of the first early adopters. Even before I got up to work directly with you guys, it was Russ Warren like trying to get me up there to work with his group. So kind of go into your background and where you're from and how you got into this, and maybe a little bit of the story of what HSS is.
So, like you said, I've been practicing for about 23 years. So I started off in Chicago. I'm from Chicago, born and raised. So my career started there. And about I would say about 15 years in, I knew that I needed to make a change. I knew that my life and my career wanted to go more of around the elite athlete, professional sports area. And I was branching out. I was branching out a lot of different places, seeing what was out there, ready to make the change to Chicago. And two of my colleagues, Terrence Scroy and Patrick Ignona, they worked with me in Chicago, and they had both come back to the East Coast because that's where they're from, and they both started working for HSS. And they kind of approached me, and they're like, "Hey, we're really doing different things here. This is kind of the place that, with what you want to do." where you want to be. This is where you want to be. And, my first thought was, really, New York? I don't want to move to New
Yeah.
York. Like, who wants to move to New York? Uh,
Yeah.
but finally it got me here, and, I saw what they were going to do, and, met, Dr. Brian Kelly on that first day. And, we talked about, what sports is about at HSS, where we're thinking of going. And I knew that was like the place that I needed to go to further my career. So, I started off there, and my life just kind of changed from kind of seeing everything to migrating a little bit more toward the lower body. So it was, it started to migrate more toward the hip and the knee, hip arthroscopy, ACLs, and a lot of knee cartilage work as well. So Dr. Riley Williams works here. He works with us at the Weston
Yeah.
Sports Medicine Institute. He's been at HSS since, the early 90s. And he's one of the pioneers in cartilage surgery and cartilage replacement. And it was early on in my start with HSS that we developed a relationship, and we have a great relationship now. But a lot of my experience with cartilage in the higher level athlete and professional athlete has come from patients of his, and we've worked together to kind of nuance this niche of cartilage. So I think it was one
Yeah.
of those things where we started off, and when people would do cartilage at the beginning, it would be hands off. It's like, no, 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 don't, we just fix that, don't mess with it.
Yeah. Don't touch it. Yeah.
Yeah, you don't want to touch it. And my start with BFR, it was funny. It was with a cartilage patient. It was a high level basketball player having a hard time getting strength back, just having a hard time loading his knee. And this was, we were just having a hard time because before the onset of BFR, like, Johnny, like, there wasn't anything around. So what do? You're doing table stuff. You're trying to do stim. You're
Yeah.
trying to do whatever you can
Watching
to
the
this.
muscle waste away,
Yeah, it's
right?
just like, and you're pulling your hair out trying to do it. And so Pete Drayevich, who was with us for a long time, Pete brought us to
Well, yeah.
HSS as well. And Pete Drayevich said, Snay, he had met you. He's like, there's this new thing called blood flow restriction. So I'm like, hey, like we were talking about it a little bit. And the funny thing is, his player was there, and he's listening to us, and he taps us on the shoulder. He's like, oh, blood flow restriction. I got one of those units. And we're like, well, what do you mean? I don't think you can get those. He's like, well, I got one. And so we're like,
Yeah.
okay, well,
No, that's
let's,
an insider secret that a lot of these
yeah.
players have
And
these
so
Delphi units. Yeah.
we were like, okay. So one of the first iterations of the blood flow restriction unit comes to our clinic, and we get it. And, you know, it, we sit down, and we, we roll out the manual. I think Pete had even called you and said, hey, we got one of these. We roll out the manual. Pete's like, well, we got to try this out. So how are we going to try this out? So, of course, we're the guinea pigs. So he tried it out on me, and I'm like, you know, tried it out on the spot. And I think it was right from then where I was like, this is like the missing link we need in some of these cartilage patients that we can't
Yeah.
load, but we need to get the strength back. Uh,
Yeah.
and that's where it really started for me. I think after we used it that first day, it was a big push by us to say, hey, we really need to get this in the clinical setting. And you know how it was at the beginning. It's like, you guys want to do what? You guys want to tie a
Yeah.
tourniquet around patients that just had surgery. And so it was a lot of convincing and a lot of other stuff, a lot of education. And even at the beginning when we were doing it, like, not everyone wanted to buy in. Like, what are you guys doing down there? And as we've evolved and we're at the point we're at now, it's like, it's written down, like, these patients are told, like, hey, you're going to do blood flow restriction right at the beginning. You need to do it. You need to buy into it. You need to do it. It's a needed thing for this surgery. And it's just helped with my overall practice with these patients, along with our whole clinic. I mean, I don't know if you guys remember, it was, I want to say, like, probably like a year or two ago, where New York had that whole debacle, and And it was like blood flow restriction is stopped, and
Yeah.
it was based.
We know
Yeah,
that very
yeah,
well,
oh,
man.
yeah, yeah.
I
And
remember it.
yeah, it
Scarred
was
me for a
it
while.
it was a lot, and I was just
Lots
like,
of phone calls and texts.
I was like, well, what am I supposed to do? I got all these cartilage patients coming in, and you're just gonna see muscle degrade away. So, it's been like I said, it's come full circle with me where it's changed my practice and the way I treat and the way I go about seeing this patient population get back to where they need to be.
Yeah. And there was a editorial LaPrade put out in arthroscopy about doing BFR. And basically he said the complex knee surgeries, especially like the cartilage ones, are probably the biggest winners from BFR
Yeah.
because they are so debilitated for, weeks, 6 to 8 weeks, that they're the ones that if you can just maintain a little bit of muscle, that's such a huge win. So
It is. I mean, it's the, you guys all know we get strong by lifting heavy stuff up and putting it down, but
yeah.
these knees can't do this. So you need something to help them out so that they can get to that point. And like I said, it's one of those things that, if I was forced again to do it without BFR, yes, I would do it, but it doesn't make my life easier. It makes it more complicated.
So I'm gonna hit up Pete and say, "Yo, bro, you never told me you stole one of your patient's BFR units and did it behind my back the first time with
It was
reading the manual."
it was an experiment, and we knew that if we experimented on me, it's like, all
Oh
right,
man,
well,
I know.
hey, listen, Snay's legs get cut off. It's not a big deal, it's okay.
Yeah, right.
Uh,
Well, that was us with the limb
yeah,
salvage guys. They're like, "Well, if my leg falls off, I was going to amputate it anyway."
yeah,
So,
exactly.
kind of
So
the same thing. Yeah. But if anyone's going to experiment, it's going to be Pete.
yeah,
So,
yeah,
and
but
he's kicking ass down there in Florida right now.
oh yeah. I mean, listen, we owe a lot to what Pete has taught us, with pro sports and kind of pushing the
Yeah.
edge with rehab and just with everything that case. So, like with the inception of BFR at HSS, it does have a great amount to do with Pete Dravich, so, without him
Yeah.
kind of paving the way and kind of having our backs and us having his back, it's evolved to where it is now.
So I'd like to touch on two things. One, we have a lot of, younger PTs and folks like that out there, ATs, going like super specialized where you're like, I'm going to focus on the knee, or focus on cartilage and kind of tie your wagon to that. What do you think from a career perspective, like from a growth, from a not getting burned out? Because that's what I've done. I've always kind of been very subspecialized, all the way now that I go speak at conferences, they call me the fucking tourniquet guy, which
They
is
don't
kind
even
of
know your
annoying.
name
But I
anymore.
mean,
They just call you the tourniquet
I
guy.
know, but I kind of like start to find this niche and I like really get into it and I'd like to know this thing like more than anyone else will ever know it. What do you think from a physical therapy perspective of people like, dude, specialize in the knee, man, like learn cartilage?
You know, I tell students this all the time. Like, I didn't start off as like a knee specialist. And I don't think like
Mhm.
students coming out, like, if you're a year or two out and you're like, hey, listen, I'm going to be a knee specialist, in those
Right.
cases, I'm like, hey, you really need to get your reps. And what that means is you need to get a lot of experience seeing everything, like knees,
Mhm.
hips, spine, shoulders, everything. Because even when I'm treating the knee, there's an inherent knowledge of what I need to do with the spine and core as well. So I think sometimes if
Yeah.
you start early specialization very early and you're like, hey, you know what, I'm just going to do knees, I think that can be a downfall for early students that come in, that come into the
Yeah.
practice. But as you
Yeah.
start to evolve, like, I mean, it's very hard to become a master of everything. And I think that's the beauty of what we have in our clinic. Like, we have guys who, hey, like Terrence just does, he specializes in shoulders and elbows, like
Mhm.
Pat and I have a huge specialization in lower extremities, hips and knees. It doesn't mean we don't see other things, but we know that if something comes through the door and it needs that specialty, well, you're going to the person who knows everything about that. And I think when I came to
Yeah.
HSS, we were able to focus ourselves on those pieces where it's like, well, not only can we focus on the knee, but now we can get into a subspecialty of, like for me, it was cartilage because that was heavily done at the institution. ACLs
Yep.
are heavily done at the institution where other places, you just don't see the volume of that. You may see a couple cartilages and stuff like that, but you get so many reps here. It, becoming a specialist in those particular surgeries or body parts is like second nature. And, as far as like elongating your career, I think it just helps. It helps you out as a therapist in general when, like, yeah, I mean, the tourniquet guy is not the best nickname in the world, but they
No, man,
know what.
it could be X-rated if you're
Yeah,
not careful.
listen, I didn't want to take it there, but if you're gonna take it there, but I mean, they know that you're the expert in that field. So if there was, I mean, we've talked extensively about complicated cases that I've had, with like, Johnny,
Yep.
what would you do BFR with this with? There's people around that are like, we have this complicated cartilage case, Snay, what would you do with it? And so in one way, it's a general sense of pride where people are calling you where you're like, hey, listen, this guy sees a lot of this and
Yeah.
specializes into
Yeah.
it. And it kind of puts you into a different level in that way. So I think for me in my career with, like advancement and, not feeling so burnt out, it's helped, in one way, I'm just as busy. Like, you would be surprised how many cartilage patients I see on a daily basis, because we do such a volume of them. But I think for my overall career, like as I started to evolve, it was like I really got to get good at seeing certain things or like one thing. And
Yeah.
so I think now, at the age that I'm at, it's like, and like I said, I think I know people look at me as like the old head in the clinic, but it's a good way of going with it because if, some of the younger clinicians have a cartilage case, and they're not even struggling, if there's questions, they know that they can be like, oh, well, you know
Didn't
what,
know to go to
it's
you.
not a
Yeah.
big deal. Like I go to
Yeah.
Snehal and we'll
And
figure it out.
I mean, you're 23 years in and you're still doing it, and that says something, because Kyle and I are teaching all over the place, and we just hear so much of this burnout. And I think one of the I don't know if I need to go down this wormhole, but one of the problems with our profession is you have to be basically just this generalist. You never feel
Yeah.
like you are the expert. If I
Yeah.
owned a bakery, I'd want to be like, oh, Johnny makes the best freaking sourdough bread there is, and I can just focus on that. And so I think some of these folks who are kind of trying to find their way is like, dude, if you like the shoulder, just start really like trying to focus on that and get really, really good at it. And then the surgeons or anyone, the referring providers, start to be like, this guy knows shoulders back and forth. And then they just start to come to you. It's like
Yeah.
we had a call today with our buddy Tyler, who he's so baseball specific that he's like, I only work with pitchers. And it's like I work on the shoulder and I work on pitchers, or he works on everything, but he's got such a niche that he's turning away super high end clientele just because he's so good at what he does. And so
Yeah. I
I
mean,
think that people
yeah,
can weave themselves with that.
we see that problem. We see that problem where,
Yeah.
young therapists get burnt out because, it's I think part of the, we don't have this problem as much, but I've been in the outpatient world. I know how it works and business works that way and it's like it's a high volume of people coming in and it's a huge turnover rate where it's like, hey, get patients in, get
Yeah.
patients out and keep seeing people and you're in some of these places and they're like, hey, a TMJ walk through the door, and you're like, man, I don't want to see TMJ. Like, I don't know what I'm doing,
Yeah.
but you don't turn it away. It's like,
What is that?
I don't know. If a TMJ came into my clinic,
Transmasculine.
I don't know. I would be like,
Yeah.
that's why even now, if an elbow shows up on my schedule, it's like there's a problem here that this shouldn't be here.
Well, I think
Not,
even being proud enough, like I'm not great at the spine,
yeah,
and I would get those people, and I'd be like, these guys are way better, I would recommend you go to them. I've got plenty of other patients, and I'll help unload the ones that I'm good at. But
Yeah.
I would rather the experts take care of it. And you see that in orthopedics. It's like if I walk in with an Achilles rupture and it's a shoulder surgeon, I would hope you would say, "I'm going to send you to the foot and ankle guy
Yeah.
and do that." And we don't do that enough in our world.
I think we need to do it more. The good thing about the
Yeah,
city and the institution we're in, that we have people who specialize in everything. So if it is
yeah,
someone and it's like, hey, listen, this is a spine case, or a concussion case. I- We're not the generalist, but I can find someone who's
yeah,
very good for you to do
yeah,
that. And so you get better. Like, we always just want patients to get better. We don't want to run them through the mill. We want them to get better. So let me send you to someone who can do that.
I think
yeah,
that's a big piece, honestly, is like if you are really feeling like you want to kind of specialize in something, your geography may need to change. Because
yeah,
if you really wanted to specialize, even where I am in like Ventura County, if you really wanted to specialize in like a particular post op diagnosis, it'd be pretty tough because the volume isn't there. And so you kind of have to be the generalist in some respects. So you could probably get close where I am, but if you're out in kind of like the very very suburbs of a region, you probably need a job that's down in the city where there's just a bigger volume of folks, and a lot of times tied to um, a bigger institution, like you are,
it's
Snay.
it's
That
and that's for
helps a
sure
lot.
hard, but you get so many people that are so freaking burned out right now. And like Snay went from
Yeah.
Chicago to New York and created this niche. And it's like, man, if you're like, I spent all this money on my education, all this time, and I'm done, I can't do this anymore. Well, maybe do you
Change
like anything
geography.
in therapy? And
Right.
then
Yeah.
yeah, change your geography, do something. I did it,
Yeah.
and I
Everybody,
got super specialized.
it's I kind of needed to do it. I think when I was in the
Yeah.
outpatient world, when I was back there, it's like
Well,
if I
Chicago
didn't,
sucks ass in the winter, so you have to
it's
do that.
it's you are correct. It's painful. It's painful in the
Yeah.
winter. I think the biggest thing with Chicago was when the sun doesn't come out and it's just cold, and then you got one newscaster or weatherman that has to say it every year. It's like, oh, you know what? It was warmer in Alaska today than it was in Chicago. It's like, I
Oh.
I don't need to hear that. Like, that's
Come
maybe
on,
1 year
bro. Yeah.
you did that.
And the
Is
White
that
Sox suck.
necessary?
I mean,
Yeah,
they
yeah.
have to
Yeah.
throw in all these little jives.
Yeah. So, it was one of those things where I agree with you. I had to leave Chicago because if I didn't, I would just become one of those people that just got burnt out of a profession that,
Yep.
I I did this for a reason. I knew what I wanted to do. But yeah, Kyle's right. If you're not seeing the things that you want to see and you want to be somewhere different, part of it is you being like, all right, I got to make a change. And if that means me moving from California to New York, or whatever, to try to be in this institution or see this type of patient, then you got to make that change. Change is hard. I think it was hard for all of us, but if
Yeah.
you are very passionate and you want to do something, and you definitely don't want to get burnt out, it's up to you to try to make that change as well.
You're here.
So I need to get off this soapbox, but let's go into cartilage, man. Explaining, kind of what these cartilage injuries are. And let's just stay knee here. So, you know, what the differences are in the cartilage, injuries that you see, and what the surgical or non-surgical kind of procedures are, because for a while it was like microfracture, and the world's changed quite a bit.
That's
Um,
Yeah.
we call microfracture the worst surgery that happened to mankind.
yeah.
You know,
I-
I'll go into that a little bit more, but I mean, as we all know, if you have some sort of cartilage injury, cartilage is not growing back. There's no, there's things out there like, oh, stem cells will grow cartilage back, or PRP is gonna grow cartilage back, and it doesn't. Like, there's nothing out there that grows cartilage
I
back.
thought we just did some upper extremity BFR and got a growth hormone spike and boom, cartilage. You're telling me that
Yes.
shit doesn't work, Snake? What the
I, I
hell?
I wish it did, but
Stem cell
unfortunately,
upregulation.
yeah. That's like everyone asks, they're like, oh, well, Snay, what about the stem cells? And I'm like, you can go ahead and do that. I think that
Yeah.
orthobiologists, I think, are great. I think that stem cells, PRP, for cartilage patients, like degraded cartilage, if you're doing some of that orthobiologics, like a lipogems or a PRP or something like that, those orthobiologics are great because they're signaling that horrid knee, or that just angry knee. They're giving it that signal to say, like, hey, let's quiet down a little. Let's reduce this inflammation. Let's quiet down a little bit so that the rest of your body can do what it needs to do. So, for a non-operative cartilage patient, with some kind of cartilage wear, not everybody needs a surgical, fix for it. Some people do very well with orthobiologics and then strengthening. I mean, in our clinic, strengthening is the eh, the determining factor for everything. And with cartilage patients, like with cartilage in the knee, it is quad strength that is our biggest factor. The first thing I'll do is, if a person is coming to the doctor, like, let's say they come to Dr. Williams and they're like, hey, listen, I've had this problem in my knee for years, and my knee hurts, and they do an MRI and there's a little cartilage lesion in there. The first thing that will happen is, before any sort of tests or anything else, he'll say, I need you to go downstairs. I need you to see these guys. They're going to do like a physical assessment just to see where you're at. We'll order the MRI, we'll do everything, but I need all these pieces. Because I think in the past, what would happen is, you get an MRI, there's a big cartilage lesion. It's like, oh, well, we're going to have to fix this, that, and the other. And sometimes, like, our part of it, the physical therapy part or the strengthening part, was just put off to the side. And so now I
Yeah.
think it's changed, where it's like, we will straight up strength test these patients on that day. We'll do a little HEP evaluation that involves a strength test to see, where are you at? Like, is your strength in the normal range where it's supposed to be? Or is it close, or is it way far away? Because a lot of times, if that strength is not there, and it's like you got like a 50 or 60% deficit in your quads, the first thing will be like is, well, if you strengthened up a little, you may get rid of a lot of this pain that you're having. Maybe you
Yeah.
don't need a
Yeah.
surgical
You can
intervention.
go up the stairs and
Yeah.
yeah.
And I think that's where, patients will come to us and they're like, I've tried to strengthen, I tried to work out, I used to work out all the time. I did squats, I did lunges. I can't do any of that anymore because my knee hurts. And, techniques I would use in the past would be like, all right, let's deload the knee. Let's get you to kind of get a little
Mhm.
pressure off there. Let's get some strength on. Now, for me, if it's like, all right, listen, you have a huge strength deficit. You've told me that you can't work out because, your knee hurts when you load it. All right, hop on the table. I'm going to strap this machine to you. We're going to start with this.
Mhm.
So BFR is like a first thing that I will do with these non-surgical patients, to be like, all right, we need to get the strength up. And as you all know, we hook it up to them and they're like, their eyes light up and they're like, what are you doing to me?
Yeah.
And they're like,
Yeah.
this is really hard. And I'll try to explain to those cartilage patients that this is going to be hard. Like, it's going to be hard to get strength back. But, we'll go through the process of getting strength. And, let's just say strength does come back and they got a good amount of strength, but they still have pain. Well, then I think, you need to get some kind of surgical intervention.
You're not changing the anatomy. Yeah.
Exactly. And so I think before, it used to be microfracture. You do microfracture to everyone. And, if you look at it, I think microfracture is still one of the number one surgeries that's performed because it's very easy. You drilling some holes in there, and
I could do it.
Yeah.
Yeah.
Yeah. Just poke all in there and just do it.
The easiest orthopedic surgery there is. Like, I don't
And
even know if I could cut a meniscus, but I could poke a hole
yeah,
real
you just
easy.
poke some holes in there.
Yeah.
Uh,
Yeah.
and the thing was is that it's not cartilage. That fiber cartilage that gets produced sloughs right off. So if you're looking at some high level athlete, or let's not even say high level athlete, some active adult population. It's not like when my dad was 50 years old, he's like, well, I know what I'm doing now. I'm sitting on the couch. I'm not doing anything. 50 years old now, it's like, hey, I'm out. I'm playing tennis. I'm doing all this stuff. That fibrocartilage is not gonna it's not gonna hold. Like, we've seen it
Yeah.
doesn't hold. So then it's like, all right, what do we have? And now, like, ever since like probably the mid 90s to about now, osteochondral allografts and autografts are used much more readily for this patient population to help them cover those focal cartilage lesions. Allografts used for, bigger cartilage lesions that are out
Yeah.
there. And, autografts like for, like they'll take cartilage from a non-weight bearing portion of the knee and basically like mosaic plasty that cartilage lesion that they have in there. And, from our experience here, that is a much more hardy surgery to get back to athletic activity. And at first, it was thought that, oh, we'll get back to a little athletic activity. You want to play some recreational tennis or, some, stuff like that. It was like that. But we've shown
Just
that.
doubles tennis, only doubles. That's
Oh,
what one
yeah.
of our surgeons would say.
But well, we'll go with singles. Like, you want to play singles tennis, you can do.
Maybe
But
pickleball or doubles.
That's why
That's
you
all I
gotta
yeah,
can
mix
do.
it in
yeah.
pickleball now.
But we've
Yeah,
we've
that
seen
wasn't
that
around back in the day.
we've seen you can put these cartilage plugs in these patients and they can be high level athletes and return to high level performance sport and perform at a high level. Uh, I think we've done a number of cases in the last, like, at least, the last 8 9 years that I've been there. I know Dr. Williams has done much more than I've even seen, but you know OC allografts and autografts are a hardy surgery for this patient population, but it comes with work. There's work that's
Yeah.
involved with people coming back, and they're not handle with kid gloves surgery anymore. Like, these are very hardy grafts that if you rehab them right and you give them enough time to heal, they can last in a high level
Yeah.
athlete.
Yeah, and I think it's progressed, back in the day, because like when, it was Genzyme originally that, it's like it became ACell or whatever, but the DOD, we were part of the group that was researching that. And, it was like, oh, it's almost like an Achilles repair.
Yeah, yeah,
Maybe some gentle passive range of motion. And then they would almost get these like proud, articular overgrowth,
yeah, yeah.
because it just went crazy because there was no like any stress or strain there at all. And they'd have to go back in and, take that back out, which Lord knows what that would have done. So, okay, let me say, like, so I'm an NBA point guard. I've got a big O brand new honking MFC lesion, like grade 4, big. What would Riley do for someone like that? I get it. He's going to send them down, make sure, he's already got a strong quad at this point. But, he's probably sending you guys, get some testing, prehab. What would be his surgical approach for a pretty decent size lesion on a pro player's MFC?
I think depending on the size, if the size is too big, we kind of have to go with an osteochondral allograft, because of the size.
Allograft, yeah.
But what we
And
have
explain
seen a
what that
lot.
is so everyone
So
knows. An osteochondral allograft.
osteochondral allograft, we basically, the graft is coming from an outside donor. It's from a donor cartilage. They come in different sizes from a donor cartilage. It's tested, make sure of infection and stuff like that. And that donor cartilage is then placed inside of your knee. What they'll do is they'll space out, around the cartilage lesion. They'll cut out a little hole there so that this little cartilage plug will just press right into there. Uh, So that's where an allograft comes into place. But we have seen osteochondral autografts in this situation work well too, like the mosaic plasty sort of region. We've been doing a lot more of those in our higher level athletes that kind of come in. So it would be one of the two, depending on what the size is, to try to do it. I think we've seen a little bit more in the last couple of years of autographs just doing a little bit better time wise
Mhm.
for things like this. But cartilage is one of those. It it's very complicated. Like we've seen huge, huge allografts that we put in some people, and they do great. It's like, wow, look at this person. They
Mhm.
are just killing it. And then we'll see like, a dime sized one, and you put an autograft in there, and the person is like, yeah, it's ridiculous. I can't get back to what I need to do. So, I wish it was one of those where it's like, oh, smaller focal lesions do better. Bigger ones
Yeah.
are harder, but it's
No,
it's
you never
all
know, right?
you don't know. It's not like one of those where it's not like an ACL. An ACL, I
Yeah.
always say, like in our clinic, an ACL is easy because this is someone who acutely hurt their knee. Their ACL is torn, but this is a fairly healthy knee. Like these knees, they look good, if you tear your ACL, there's some trauma, maybe bone bruise, but all in all, the knee is a healthy knee. So you reconstruct the ACL and, you go through the rehab that you need to go through. And it's long, it takes a while for an ACL to heal and all that stuff. But cartilage is this is like a minefield of
Homeostasis is
knee.
gone, right?
Yeah,
Yeah.
it's just a cathartic knee. Like it is
Yeah.
angry. And so you are entering a region of just angriness, uh,
Yeah.
and trying to plug up this little focal region, which you're doing. But then you got to remember that this knee has come with a lot of trauma. These aren't acute injuries, so it's a lot to get them out of movement patterns that they've had for a long period of time, deloading patterns that they've had for a long period of time. It's more than just replacing the cartilage and then saying like, okay, we're ready to go. It's a lot of re-education to this patient population and teaching them that, hey, this is a knee that you haven't loaded in a long time, and you're gonna still avoid loading it, but we got to teach you how to do it, all while managing this minefield of a knee that can swell up at any
Yeah.
time.
Get
Uh,
pissed from anything.
yeah, exactly.
Okay,
Uh,
so I am an allograft or autograft, and I'm going to be down and out. I've had this procedure done. I'm going to the best. Riley's doing it, and Snay's going to do my rehab. Take me through an HSS program here. Not even in all the BFR, but definitely add that in. But what are you doing when you first see this patient? What are you talking to these patients about? And what's the progression? And then, you're really good at bridging back to return to play. So that's the hardest part.
yeah,
It's, I think the easiest part's the first 3 months. It's
yeah.
what's the 6 to 9, 9 to 12.
When they come in the first day, weeks, I go over and I explain exactly what went on, what we're doing, and what the goals are. If it's a professional athlete, the first thing I do ask them is, I really ask them like, okay, what are we doing? Are we are we going for another year? Are we going for another contract? Or are you kind of just wanting to do this so you have a healthy knee for afterwards? And depending on what the answer is, that's where we're gonna go. If I get someone and they're like, "Hey, listen, I'm just listen, Snay, I just want to be healthy and I think I'm done." It's like, okay, great. We have a lot of time to get this to be the way we want it to be. But if you're on the other end and you're like, "No, no, no, uh, I'm taking another shot at this," it's like, all right, if you're gonna take another shot at this, I'm in it with you. Like, here we go. So if you come in, like usually we start to see our cartilage patients anywhere from, I would say, about 3 to 5 days afterwards. Uh, and it's very basic at the beginning. At the beginning, the instructions are, I need you to get a quiet knee as soon as possible. So that means you need to be taking your anti-inflammatories that you were prescribed. you need to be icing the knee. I know there's probably someone who's going to listen to this podcast and be like, "Oh, ice the knee! Like you told, oh, why would you ice the knee? Need an inflammatory process."
Fuck off,
Yeah,
whatever, man. Yeah, don't worry about that.
you haven't seen a
Yeah,
cartilage knee. Like, listen,
that's a great blog post. It's a
yeah,
great
yeah,
blog
yeah, yeah,
post.
yeah.
Yeah,
You need it. So, icing is an inherent thing that they need to do, and it's edema control, because I do explain to them that they usually don't have pain. This is not a painful, they're like, "Oh, I feel fine from the surgery," but
yeah.
I try to educate them that if you overload the knee, you're probably not going to get too much pain. You're probably going to get a lot of swelling. Increased swelling in the knee means quad's not going to turn on. So right at the beginning, I'm like, we need to get that swelling out of the knee. I need you to work hard
Just
on
cool
that.
that thing down.
Yeah,
Yeah.
all the time, like live in your game ready. I want you to do it all the time. I want you to be icing all the time. But then the other thing is, I need you to be able to move this joint around because it hadn't moved around like it wanted to before. So it is a huge amount of patellar mobilization. Like I with my ACLs, I tell people to become obsessive compulsive of moving their patella around. With my cartilage patients, I'm like, you need to move this patella around. I cannot get it stuck, because if it gets stuck down, motion is not going to be there.
And
So
there's
it's like,
no concern if you have a
no.
retropatellar
I mean,
lesion,
listen,
right? I mean, I had a
I'm
surgeon one time was like, "Oh, be careful with
uh,
those mobilizations," and
now
it's
listen,
like,
I totally get it, but I just don't think sometimes, when surgeons say that, I don't think they understand how much we're moving the patella. I'm not
yeah,
jamming that thing down and grinding
yeah,
it
yeah,
against the trochlea.
yeah,
I'm
yeah. We're not
gently
doing
moving.
like prone. I had a
No,
CI
no,
that had me do prone patellar mobilizations
no.
where they would lay prone and they would do it. That's how we teach them for their home
Oh
program, which
man,
actually it was actually
that's
probably good, but terrible at the same time.
yeah,
That's
that's
that's pretty
aggressive.
aggressive.
Yeah.
But yeah, we're not doing that, right? So you don't have to
No,
worry
no,
about it.
and when I send them home with self-patellar molds, I'm like, listen, you don't have to move it as much as I do, because you're not going to do that. You're going to get a little freaked out. But I need a little bit of movement. I need a little superior inferior movement, because that's what's going to get the knee moving. If you don't have, for all the younger therapists or students listening, knee 101, if you don't have patellar mobilization, that knee is not going to straighten out. It's not going to
And
happen.
it's
You can
yes, thank you for that, man. Because I think it's almost an afterthought lots of times. It's
it
like,
it
okay, yeah, do it, good.
yeah.
And if you don't put the emphasis on it, because it's so true, man. If that thing binds down, it's
Yeah.
over.
Me and
Yeah.
Pat in the clinic, it is one of the biggest things where, like, patellar mobs are not just do them. They are a necessity. So we expect you guys to be
So what's your technique? Do you have a special way? How much do you tell them to do it? Is it just do it non
I
every time you check TikTok, do a
uh
patellar mob?
well, that I usually tell them, I'm like, I want you to less, if you're surfing on the phone, I don't want you to hold the phone in one hand and just gently move your patella in the other. I want you to be the weird person at dinner playing with your kneecap. Not aggressively,
Yeah.
but I just need you to move it a little bit.
Yeah.
Uh, Knee extension is huge. Like, I will do a knee extension prop. I need that knee straight so that I can get the quad to fire up. Now, there are occasions where in some of our higher level NBA athletes or basketball athletes, they have such a high amount of trochlear
Such
disease to,
hyperextension.
yeah, and it's
Yeah.
like, man, you've had such a high amount of trochlear disease. You've had a little bit of this, just extension lag for a little bit, and it may stay for a little bit. So I'm not trying to jam it down. Like, I am
Yeah. Just letting them get there passively.
I am the least aggressive person with passive range of motion. I mean, literally, the most extension I'm doing is, I'm like, hey, I want you to put your heel up on this foam roller or this towel. I want you to do it for 5 minutes. I want you to do it every 1 to 2 hours. That's what I want you to do. After five
Yeah.
minutes, take it off, do what you want to do. Repetition, frequency. And then for the flexion part of it, at the beginning, like right at the beginning, I'm like, listen, I just want you to sit on the edge of the bed. I want you to sit on the edge of the bed.
Yeah.
I just want it to hang. Don't bend it. Don't be aggressive with the flexion, because I think a lot of times people get aggressive with flexion and then the knee blows up. Just
Yep.
I let motion come back. So my beginning program with these people, like, they come in day one, I'm like, quad sets, extension prop, patellar mobilizations, sit on the edge of the bed. That's your home exercise program. And I think when people leave, they're like, really? They sent me to you and all I'm doing is this. And I'm like,
Freaking
there's a
expert.
yeah, yeah. There's a method to the madness where, we're not gonna do a lot of that crazy stuff you see on Instagram and all that. We're not gonna do that. We're gonna go simple and basic with this and then build you up with that. I think one of the big things we do with our cartilage patients is they are toe touch weight bearing that first week. So first week out of surgery, they're toe touch weight bearing. But
No matter
then
where,
no matter where.
trochlear versus
Yep.
MFC versus
Yep.
anywhere. Okay.
Anywhere. Toe touch weight bearing. But then week 2, weight bearing is tolerated. I don't take away crutches at week 2, but I'm like, listen, I need you to put as much weight as you can tolerate on this leg and start getting rid of some of these assisted
In a
devices.
brace.
Now I'll go over that in a brace at the beginning, but usually starting week 2 or when sutures are removed, we remove the bigger hinge brace. It's not even a big hinge brace that we have at the beginning. And we take that away and we put them in a soft step down brace, just like an easy pull on brace. But even that
Yeah.
brace, I only keep on for maybe another week or 2. Sometimes I even say, no, 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 let's not even do the brace. Let's just put them in a sleeve. Uh, remember,
So I'm,
we're
I'm an NBA guy with a condylar lesion that you guys have autographed. And by week 2, I'm already weight bearing on that.
yes, yes. If we
That's
really
that's so
think
much
about it,
so awesome.
because cartilage needs
It
weight
needs
to go
it.
through it. And I think,
I
and
know.
I talk about this in the clinic all the time. Like, I totally understand at the origins of, cartilage surgery and cartilage replacement. I totally understand because we've talked about it a lot why it was a very kid glove surgery. I 100% understand it. But I think one of the things I learned from Dr. Williams is, you know, again, repetition and going through the reps and seeing a lot of people teaches you a lot of things. And he would see these people come in and he'd be like, "Hey, where are your crutches? What's going on?" Like, "Yeah, I ditched those." And
Yeah.
he's like, "Those patients did well." So
I
then,
know.
he got to
Yeah.
thinking like, do we really need to do this? And we're
It's the
not
whole Dr. Shelburne with ACLs, right? The ones
Yep.
who
exactly.
didn't follow the rules did the
They
best.
they did great.
Yep.
So, we're not I don't call us aggressive. We're just more permissive with the patients. We
Physiologically.
let them do a little bit more, but we do watch them. Like, we don't, I'm not taking care of the crutches and I'm seeing this guy like just limp all over the clinic. I'm like, well, that's not going to work. You need a crutch or a cane or something to take some weight off. But the reason for the brace to be taken off is because, the both of you know just as I do, braces are inherently causing quad atrophy to happen
Yes.
because you
Atrophy,
can't
flexion gait
it,
pattern.
it's I know the brace is quote unquote locked in extension, but everybody walks with like their knee bent in
Yeah.
the
Just a
brace.
little bit of flexion. Yeah.
And so it's like we got to get out of this. We got to get out of this. And with a cartilage lesion, it's not a ligamental procedure. We're not repairing any ligament where we feel like it's if the person falls or something like that, something's going to happen. It is really a very hardy procedure. So, you know, I
Bumba.
I do tell patients, I'm like, listen, I don't need you gallivanting around town. Like, I don't want you walking around everywhere, but I do want you to start putting more weight through this. Like, if I feel like they're not progressing well, I'll bring them a step back. I'm like, all right, back on the crutch. We're going to have to figure this out. But in most cases, these patients do very well, and the quad starts to come back earlier. So I'm at like week 3, week 4, able to do stuff in weight bearing. Whether it's even just
It's
like, hey,
awesome.
listen, we're gonna do bilateral calf raises. Like, I want you to tighten up your quads while you're doing it. TKEs. Light leg press. I mean, I think people think that we're very aggressive when we're doing this, but we're really not. Like, if I put someone on a leg press with 40 pounds, a bilateral leg press, that's like no pressure through this knee, but they're getting the motion through it. And I
Any
think
range of motion limitations based on the repair?
not not with the cartilages that we do. Range of motion.
Even when they're leg pressing.
Oh, like what I'll do at the leg press, I'll limit the arc at first. Be like, hey, listen, let's go
Okay.
from 70. Like, I only want you to go down to 70 at first. And it's really because the knee is still tight at that point. And again, I'm not trying to
Mhm.
push knee flexion. Uh, and I always tell people, I'm like, don't push the flexion. Just let it
Let it
come.
happen.
Let it
Yeah.
come by doing the bike. Get on the bike, just start moving it around. Then light knee flexion. Get on a step, just start to translate your knee over your toe to get a little bit more flexion into it. And then as we start to go through it, like I said, a lot of these patients come in, they've deloaded their knee. They've learned methods to deload their knee, and that's how they strengthen stuff. So it's a matter of kind of getting them to the point where it's like, okay, yeah, you've deloaded your knee, we've quieted it down, everything's good. We need to reload that. So, like
Mhm.
we always complain on our podcast that the knees over toes guy was, basically stole our thunder because he made a lot of money and, over knees over toes.
My
I'm
my
not hating
my
on the guy.
buddy's doing that right now, man. He was
Yeah.
asking me to, my thoughts on
Yeah.
it, and
I'm
I
not,
tried it, dude.
I can't do it.
Man,
I can't do
I
it. Like
couldn't
my
do
knees, I can't do
man.
that.
I have no ankle mobility.
Yeah. And
Oh,
and that's why I say I'm like, I'm not hating on the guy. I'm actually envious because,
yeah,
he's making
yeah,
money over it, but you do need to incorporate knees over toes or knee loading because now you can load the knee. If you kind of get into these
yeah.
aspects where it's like, all right, we fixed that cartilage, don't load the knee, you're never going to get back to a higher athletic type of population. So,
Right.
we'll start with a lot of that. BFR will start very early.
Yeah, let's go
Usually,
in. Let's go through your BFR protocol.
I'll do BFR starting probably visit 2. Uh, when they usually come and see me, they'll come and see me like on a Wednesday or a Thursday, something like that. And over the weekend, I give them the exercise program that I just told you, quad sets, everything else. By the time they come into me the next week, I just want to see a quad set, a good quad set. That's what I'm looking for. Once I have that, that's when I start BFR. So my BFR protocol at the beginning is I'll do BFR with Russian stim, 10 on, 10 off.
Hell
I'll set
yeah.
the BFR for 8 minutes and I'll set the stim for 15 or 16 minutes. So I'll tell them, I'm like, hey, for the first 8 minutes, you're going to have BFR on. You're going to do the same stim that we do all the time, but it's going to be on for 8 minutes. On for 10, off for 10. And I let them cycle through that. The second 8 minutes, the BFR is going to be off. That's when you're going to finish out the protocol. So I start BFR early with that. People have asked me, like, Snay, if they don't have a good quad set, do you start? And that's when I'm like, I need them to have that much. I just need them to
Yeah.
have that little quad set so they can go.
No, it's
But
a perfect
like
population with STEM and BFR. I mean, if there
exactly.
was ever a population.
Yeah. And
Yeah.
so that's where I'll start it. And then it will progress fast depending on how the quad comes back. If I get good quad contraction, we're going from, BFR with quad sets to shorter quads. And what we're trying to promote with all these patients is not just we're trying to promote active knee hyperextension, a terminal knee extension on the table. Like we're not
Mhm.
just trying to get to
Mhm.
a quad set. We want them to get to that terminal knee extension angle because they can do it now. And again, like I understand if we do some sort of patellar cartilage replacement, people are a little bit off, like, oh, don't compress the cartilage, but it's a short arc quad. We're
Yeah.
not putting any weight on this, and even we will uh, open chain knee extension is a huge part of what we do. Once they can get from that
You
easy,
made Kyle's day. Just
yeah, listen,
You got to
you
do it.
can't
It's the only way to get the quad.
you can't get the quad strong. Like I
Can't
don't
do
know
it.
how you're doing it. I just we're a big population that's like, listen, I'm not against squats, I'm not against lunges, I'm not against any of that.
Oh,
But if you want isolated quad strength to come back, long arc
that's
quads, leg
who's
extension.
afraid of the
And
big bad wolf. Yeah.
no, and when we really think about it, with the adjunct of BFR, like I would say at a good going through BFR, no weights, leg extension, edge of the table early. If the person can do it at like the 3-4 week mark, I'm doing it. It all depends on the patient how they're coming back. And the thing
Yeah.
is I'm not putting any pressure on anything doing non-weighted leg extensions with a BFR. I'm
right.
just getting that muscle to do
Learn to
what
fire. Yeah.
and it hasn't done it. It's never
Yeah.
done that. And I'm not going to get back that quad strength that I need unless I'm doing exercise like that. And then once that happens and once the person is off crutches, which is usually at the latest 4 weeks, then the opportunities just start to kind of come up. Then I'm progressively loading these patients as much as I can. And I wish I could tell you, like, hey, at 4 weeks I'm doing this, at 6 weeks I'm doing this, at
Yeah.
8 weeks.
No, that
It's
we
when
don't roll like that. We get
yeah.
it, man.
I,
Yeah.
I think I usually tell people like the first time I will strength test somebody is at 12 weeks.
12 weeks. Yeah.
I really think, and could you do it earlier? Probably, but I don't think you're going to get any meaningful numbers at that point.
Yeah.
Giving people a full 12 weeks to try to get their strength back is, I think, the most optimal thing at that point. And then you can start to build a plan from then to be like, okay, how are we going to get this person from where they are at 12 weeks to the numbers that I need to see for them to be able to run and then to perform in high level sports, which they need to be at.
So a
I'm
couple of things
curious,
I
do
always
you?
get, especially when I speak at like orthopedic conferences, is what about the suture? And obviously you're starting early, and we know Riley's bought in, and I'm bought in, and I don't worry about the suture at all. Have you seen any issues with the suture?
We haven't, we haven't seen any. You know, I think the only thing that kind of gets me at times, whereas if someone comes in, like, I think you guys even see it, like, there are some patients that are like, I'm looking at you and you're not going to tolerate this
Yeah, yeah.
BFR
You
at
couldn't even,
all.
I couldn't even check your blood pressure
Yeah,
because
it's
that
like,
the blood pressure would freak you out.
yeah,
Yeah,
it's like,
yeah,
you know
yeah,
what? We're gonna go traditional with you. It's not
yeah.
gonna happen. But for someone who's healing nicely and everything's going well, 100%. We haven't seen an issue with, having sutures in.
Dehiscence, bleed outs, stuff like that.
No, no. I mean,
Yeah.
again, other people may have seen it, but we have not. We haven't seen it.
Yeah, that's typically what we've heard as well. But the surgeons lots of times are like, I want to wait for the sutures to come
And,
out.
you
I
know,
know we talked a little bit about this prior.
yeah. I listen. I don't hate on anyone if it's like, yeah, okay, if that's what you want to do, that's great. I'll follow the protocol. It's fine. I just feel starting off early, these patients actually, when they see their quad firing on and they see them getting fatigue in their quad, in one way
Yeah,
it makes them feel good because they're like, I haven't felt that in
I'm doing
years.
something.
Yeah, I'm
Yeah,
doing this
yeah,
is this may work. Because listen, people go in for cartilage surgery and they're like, is this gonna work? Like, my knee hurts and my knee's gonna hurt, and it's, are you guys are saying you can fix this. And we've shown that, yeah, we can. Like, people come in and they're very happy. Like, by what we try and tell people is by the 6 week mark, we want you to feel normal, as in, hey, I can do my regular
walk
activity,
around.
walk
Yeah,
around, live my day. And your pain should be less than what you had before. It may not be gone, but it should be significantly less, where you're like, wow, like, this is going well. And then the big ask for them is, all right, we need to change some stuff that you have taken out of your life. And that means we need to get you strong. We need some level of fitness back in you.
yeah.
And that means if you weren't doing any strength training, guess what? You're going to have to start that. And if you were doing some strength training, guess what? You're going to have to do more strength training in
Yeah.
order to kind of get good and feel good.
So another one I get is the swelling's calmed down enough, we can start something like BFR, but they're still swelling. And then I'll get from the surgeon, well, that's going to cause more swelling in the joint. Have you seen like increased swelling in the joint itself from doing BFR?
I think the opposite. I think sometimes
Yep.
when we use the
Well, and
BFR,
that,
like,
Luke Hughes, our colleague, he showed that in his ACL study. They had
yeah,
less swelling over that 12 weeks.
because
Same
I
with these
think,
cartilages.
yeah, I mean, with cartilage, it's a little bit different. With ACL, like I said, you're working with a joint that looks good. Like, it's a good looking
Hmm.
joint. So, the swelling's gonna come out of there. In cartilage, you're left with a little bit of transient swelling sometimes because of the nature of the joint. And that's the whole point of trying to get the knee to calm down as much as you can, so you can kind of see what's going on. I think that's one of the big things with braces as well, because you got this joint and you got this capsule and it's inflamed, and it's just it's angry and it's tight, and then you do this surgery and it makes the joint more angry because you mess with it, and now you put it in this brace. And so
Yeah.
what does it do? It contracts and it gets tight, and it's like,
Yeah.
the whole point of moving these knees around and trying to get the swelling out is key to this. But I think with cartilage patients, that actually helps out a little because it's opening up
Yeah.
all that stuff for things to drain out. I do always get concerned. Swelling is my major concern, but I don't see that happening with the BFR. I don't see
BFR. We
that's
don't
not the
either.
cause of it. Yeah, the cause of swelling in a cartilage patient is usually overloading,
Yeah.
but not from the BFR. At least I don't see it.
So, okay, you're starting early on, just getting BFR, getting the muscle to learn how to fire again, using stem. Once you get a quad contraction, they're continuing, you're progressively loading them with BFR, be it long arcs, short arcs, maybe getting onto a press. And then they're starting to get their muscle back. You guys are around 12 weeks are going to test them, right?
Mhm.
At what, we get this all the time. When do you stop BFR? Like what's your progression?
So and this will be. I think this is where people
Because
are.
I just say never,
I,
just do it
well,
forever.
well,
I'm just joking.
actually, I don't stop. I don't stop. I just change when I'm doing it. So, if I'm seeing a pro athlete and they're coming in 4 days a week, let's just say they're coming in 4 days a week. One of those days is a deload BFR day where I am
Yeah,
not loading the joint, but I'm getting some work done.
I love that.
So,
Yeah, we did that too.
yeah, a lot with so I, I am a full component of, hey, once that muscle comes back, we need to load this. We need to do lifting activities. We need to do split squats. We need to do leg extensions. We need to do squats. We need to do all that stuff. But I still use BFR in my arsenal because I can, especially with these cartilage patients, I can deload the joint, but I know that I'm getting muscle work done. So, I'm not solely doing BFR, where at the beginning it's a lot. Like at the beginning, it's a lot of
Mm.
BFR that I'm doing because they can't load the joint. But
It's
near
the
the
bridge.
latter
Yeah.
phases, it's like, all right, I'm still using it because I may have worked you hard for 3 days. I may have done that. It's like, hey, we still need to get some work done. Let's deload the joint because I don't want that joint to get extra pressure and, swelling and whatever. But I can use a BFR and really get you to work. So that's how I keep it in my arsenal, throughout. And I even tell a lot of people afterwards, I'm like, it's not a bad adjunct therapy to do every once in a while because you
Yeah.
can get work done by not loading a joint, but you can't do just that solely. Where at the beginning, it's like, all right, come on. They hate it because it's like, you're going to put that machine on again. It's like, yeah, we're going
Yeah.
to put the
Yeah. Yeah. If you put that damn thing on, do.
yeah.
When you turn it on, they're like, ah.
We have three in our clinic. So sometimes it's just beeping going everywhere. And the patients, they
Yeah.
look at each other and they're like, all right, well, I guess I have some company doing this. I'm like, yeah,
Yeah.
we'll talk to each
Yeah.
other. We'll
Yeah.
talk to each other.
Then these pro guys, they get their own units through workers' comp. So then they
Exactly.
got to go
They
do
just
it
come
with
in
the
with their
teams
own.
after.
And at the beginning, when I used to explain BFR to people, when it wasn't so much in the pro realm and everything, I
Yeah.
explain what I'm doing, and it's like people would be like, "What are we doing here?" But now, like, I just pull it out, and they're like, "Oh man, you guys got that here
Yeah.
too?" I'm like, "All right, all right, I don't have to explain anything, so just lay down. I'm going to strap it on you next."
That's funny, man. Are you primarily just going BFR quad? Are you doing like quad? I'm going to do some posterior chain. I'm going to, in the early phases, kind of hitting multiple muscles. Or are you just, we're just going to quad this thing?
I I do a lot of quad. The reason being for me is I'm just trying to get the most bang for my buck in the time that I have
Yeah.
allotted to
You've
me.
got 3 units and a lot of patients. So,
Yeah, yeah. It's like,
yeah.
I'm just trying to get through. And like I said, we only have three machines. And, like, there's always a line like, hey, you done with the BFR? Because I
Yeah.
need it.
I
So
know. I know.
we're trying to get it through. But, with these patients, quad, hamstring, calf, I don't think there's a problem with doing anything distal to the cuff. I think it all is needed because when you look at these cartilage patients, it's the quad is degraded a lot, but it's the whole leg. They don't have a lot of strength in the whole leg in general.
Yep.
So, if I had someone and I had a lot of time, I'd be like, hey, listen, we're going to do calf raises, BFR calf raises. We're going to do, single leg bridges, or, for hamstrings, I'll
Go
put
ride a
their,
bike or
yeah, so, something like that just to kind of get them in there. So 100%, if we had more BFR units, which we always try to push for, we're like, oh, we'll take another one if no one's using
yeah.
theirs, we'll take it.
I deal with your HSS purchasing department, so I know what it's like.
I don't think they like it too much, but we're always like, yeah, just get one, like,
Yeah,
we're not paying the bill. But at our end of the clinic, we do have a lot of them. But we've shown that we have a lot of them because we use them, and we have the patient population
yeah,
that needs them, and
yeah.
it's asked for. It's asked for by the surgeons at this point, where it's like, hey, listen, I need you to be doing some BFR. Or if they're going to another clinic, it's like, hey, are they doing BFR training for you with this? We need it. We need you to do this. So, it's made leaps and bounds above what we even thought it would. We thought it would just be like a rehab space sort of thing. But it's
Yeah.
not. There's a ton of doctors at HSS that believe in it. They've seen what we've done with it. They've seen it with their patients, and they advocated for it at this point.
Well, that was just cool. When I did the course up there with you guys, some of the surgeons sat in, not through all of it, but they were kind of popping in and wanting to listen to it. So you could tell the attention was there.
Oh yeah.
Do
Oh yeah.
you we're around 3 months now. Do you guys ever get repeat imaging that could potentially be high res enough to see anything with the cartilage?
So at 3 months, there's always an MRI that comes through, just to see where it is. And we try and encourage patients two things. We try and encourage them, don't just keep getting MRIs because you think that something's going wrong, because it's a very
Yeah.
low threshold of things going on. Like, we've heard people say like, "Oh, I think my cartilage plug collapsed," and I'm like,
It
"What
came
is that?"
off.
And
Yeah.
I'm like, "The thing's not coming out. Like, it's there."
Yeah.
So at that MRI, what we're really looking for is a nice cartilage line that's filling up that hole. Now, above, there's still bony edema. The bones start, still needing to grow in and stuff. So when you look at it on the image, and if it's someone who doesn't deal with a lot of cartilage looking on the other side, and it's a radiologist or whatever, it's going to look horrible. Like, the thing looks horrible.
Yeah.
So we also encourage patients, which doesn't work all the time. We're like, hey, listen, wait to come in so the
Don't read
doctor
the
can,
report.
yeah, they
Yeah.
can explain to you what's going on, so that
Yeah.
you're assured that things are going on, because you read the report and it's like, oh my god, it looks like,
Right.
nothing healed in there. But it's 3 months.
Yeah.
It's kind of like taking an MRI of a rotator cuff repair at 3 months. It's like, that thing looks
So
gonna be lit
yeah.
up everywhere. Like, you're gonna think that
Most
nothing's
most
going on.
surgeons would highly recommend you never do that.
Yeah, just and so
Because I was able to order them, and I got my ass chewed out
yeah.
one time because I ordered one at 3
and
months.
and really, that MRI is just to be like, hey, is healing occurring at this time? And it's just to kind of see, like, hey, we're looking at this. Is this
Do you
coming in?
ever slow your roll or worry about it if you do see a lot of bone marrow edema and you know things maybe are a little lit up more? Like with an ACL, we got this giant bone bruise. It's like, okay, this is going to be a pissed off knee.
Yeah.
We're gonna have to really kind of watch it. Is that something with cartilage where you would ever worry about it with MRI?
I think the thing that worries me about cartilage is how the patient presents. So
Yeah,
I'm not going so much off what the MRI is showing, because if the MRI is showing some huge things, the patient has already presented in that way, where they're like, I'm having a lot of
Yeah.
pain. I can't do these things. The knee is
still
very
swollen.
stiff. It's
Yeah,
swollen. It's things like that warrant me to go to the doctor anyway and be like, hey, this person's not progressing at the rate
yeah,
that they should progress. And I think over the years, we've kind of gotten this where it's like, hey guys, that person's a little bit stiff. I think we need to kind of just raise the alarm a little bit and let the staff know that, hey, they're stiff, or this person's a little bit more swollen than what they need to. And I
yeah,
think that's what's good in our clinic, because we have, a we have 3 senior therapists that everybody can lean on and say, hey, I got an issue. Can you look at this? What do we need? And I think the way our institution is set up is the relationship between the therapists and the doctors is so in one. We can run upstairs and say, hey, we're thinking something, and it's just a very good relationship to have at the
That's the
institution.
best. That's the best.
Yeah,
Mhm.
it's great because not only if something's wrong, but if we're like, hey, what do you guys think about us doing this or us doing this? There's a collegial conversation that goes on.
Yeah, that's cool.
What are you testing at 3 months? So you're testing strength. Is that Biodex?
Yeah, we have a Biodex. We're lucky enough to have a Biodex at our clinic, so we do Biodex testing. We'll also do force frame testing as well. So I'll test hip ABA deduction, hip extension, just to get some numbers to where they are.
Yeah.
We also have a markerless motion capture system, which is nice because I've done a lot of. I think we had wrote a paper a couple years ago on the return to sport continuance clearum, and we said that there has to, if you're going to return to sport, you need to test in all aspects. You can't just test one thing and hang your head on it. So there has to be a strength test. There has to be a power test. A psychological test, and there has to be some sort of movement test that you're doing, whatever you want to use. So back in the day, we would do that, but we'd use our eyes more than anything else. We'd say like, all right, let me look at your double leg squat. Let me look at your single leg squat. Yeah, you're probably having these movement deficits because of continued eccentric quad deficits, or like stiffness,
Abduction, weakness, or
exactly. And we would just say like, all right, you got decreased squat depth, you know. But now with the markerless motion capture, you can put person in this unit, and they go through the motions, which very fast, maybe 5 minutes to do all these, and it gives you tangible data to be like, okay, 12 weeks in, your squat depth was 21 centimeters. That's where
What do you guys use?
we use Dari to do
Dari.
it.
Okay.
Dari.
Yep.
It's one of the easiest ones that we use because you don't have time to put ping pong balls on
No, I
everyone's
know.
body, and then on top
Yeah.
of that, like I don't think anyone has the resources or very limited to have a dedicated biomechanist in your clinic.
Well, I
So
did, but the taxpayers paid for it.
yes, I wish I wish the taxpayers would do that for my salary a little bit. I think that would help out a little bit.
Yeah.
But it's a good tool for us to measure objectively how this person's moving. And that's what we use
What
it
do you
for.
want to see? What do you want to see from like this is a perfect patient that just cruised through 3 months. What's a strength score you'd like to see to move on to your next phase? And what do you
I
want to measure? Like peak torque body weight?
I'll do both. Like I think my biggest numbers that I'd like to see, like in a cartilage patient at 3 months, man, I am happy if I see like a 40% quad deficit. Like I like that number at
Okay.
this 3 month range. Doesn't
That's
always
good.
happen. It is really dependent on the person, and I think it depends more on how many years has this been going on.
Sure.
If we're
Sure.
in some of our higher level athletes, I think we can get to that point. We can get to that point where it's like, all right, the 3 month mark, I'd like to see about a 40% deficit. I think that's a pretty good number to have for someone with like considerable amounts of issues in their knees for years. Peak torque to body weight, I try to, at that 3 month mark, I would like to see somewhere around like 1.7, 1.8.
Okay.
When we're measuring in Newton meter kilograms,
Yep.
somewhere around there. I've gone back and forth. Like, I think the biggest thing is like, okay, when do you run these patients? Like, when are
Yeah.
you?
Well, that's my next question. That's my next, because that's what everyone wants.
Everyone wants to run. Like, we got to run. And
Yeah.
I try.
Oh, yeah.
I try to tell cartilage patients, I'm like,
Even if they never run before, they need
yeah,
to
I'm like,
run.
I was like, are you a runner? And
Yeah.
they're like, no, but I always wanted to. I'm like, well, I
No.
don't think that you should
Now I
start.
want to do a marathon.
Exactly.
Yeah.
We do tell people, we're like, we don't discourage running. We definitely don't discourage it. But we say if you want to be a runner, you're gonna have to work a hell of a lot on your strength, because that's what's
Yeah.
gonna determine if you can run.
Yeah, catch your body weight.
Yeah.
Yeah, one of this isn't a scientifically proven fact or whatever, but we use it a lot. Like on the leg press, I'll tell someone, I'm like, how much do you weigh? Okay, you weigh 170. I need you to eccentrically control 170 pounds
Yep.
down
Yeah.
on the leg press. That
I
way
did
I
that as well.
know if you're on the treadmill and there's a split second you're going to be in a single leg stance position, your quad can take 170 pounds on it. So again, it's not,
Yeah.
yeah, I haven't read it in a paper or whatever, but this is just an analogy that I use with patients.
But yeah,
And
not a lot of people have biodexes, and so we would use that,
yeah,
like body weight
Yeah.
control with a leg press
yeah.
was always something that we
And
would
if you,
just, this is easy.
yeah, and if you can't, like, if you're 170 and I put the leg press at 100 and the whole leg press is shaking because you can't
Yeah.
control it down, we got a
Yeah.
ways to go.
You ain't running, brother. Yeah.
No, no, you're not. So, my big things are, we have an Alter G as well. So, the minimum that I would like to see before I start running for just strength is I would like to see you be able to eccentrically control yourself down an 8-inch step, with good form. I need to see at least to start off like a 30 to 35%. With cartilage patients, more like 30. The more strength I have, the better. A 30% quad deficit and at least 1.7 on your torque. At that
Okay.
point, I am okay to say, okay, you have the physical measurements to be able to start running, like in an Alter G in a low level pattern. Then there's time. I used to be a big stickler, I think at the beginning, where it'd be like 6 months, gotta wait 6 months.
Mhm.
I've pushed that theory a little bit. Like I've learned that, you guys have probably done this too. Like you learn the best from treating your patients and seeing what's worked and what hasn't.
Mhm.
I'm very not for the fact where we're running at 3 months. I think that's just way too early. I don't think things have healed up.
And why do it, right?
Yeah, it's
What are
it's
you going to get out of it?
you're rolling the dice for no reason. Like
Yeah.
you're, if I'm looking at some of my players, we're not coming back until like 10, like, so why run them that early? And with my basketball population, at this point I'm like, why are we running on the treadmill? Like, you guys gonna run 30 minutes on the treadmill? Like, we're not gonna do that. So I
Yeah.
think like my
Never,
thinking,
I personally never understood the just go to running thing. Like I feel like there's so many other things that you can do that
Ladder
are not
jokes
yeah,
running that are
and
regressed.
incline.
yeah,
Yeah.
I
yeah,
can I
Yeah.
can have you, for example, just sprint. Can you sprint on a bike for
yeah,
starters?
exactly.
Can you just move this knee fast?
Yeah,
Is that okay? And then like just little bunny hops in
yeah.
place. Like we used to be like, this is from Elf that Santa was coming. Be like, Santa, you gotta like just gotta do your Santas. You gotta like bounce it. Can you
Yeah.
do? I mean, there's so many, and you can think of other things. Like,
Shuttle, real low load
Yeah,
plyometrics. I mean, there's
yeah,
so many
just
other
in
ways.
and
Yeah.
I,
out of can you do
I
those things? Okay,
exactly,
now,
exactly. And
now
and
you're
some
ready to run.
sometimes people would be like, well, how am I going to get a workout? And I'm like, what are you talking about? Interval bike, assault bike,
Yeah, yeah.
rowing, Versa climber, like stuff like that. I'm even okay
Or
with
you
the,
hit the machine. Do, do, do,
yeah, yeah,
do.
yeah.
All right, here we go. I'm good. Oh, no BFR.
I think once I told someone, I'm like, you can do the BFR on the bike. They're like, Snake, we'll leave. We'll leave right now if you're gonna do that. So I'm like, all right, I guess we
I'm
won't
good,
do
bro.
that.
Yeah.
But running isn't one of
I'm
my,
hanging it up.
it's not one of my big things. I am okay with waiting for running because I think now a lot of my patients know that it's like, well, I need to get Snay's big thing is getting fit. I need to have fitness back. And so there's a lot of
Mhm.
ways to get fitness back other than running. But I
Yeah.
used to wait until 6 months. I'd be like 6 months. And then I started pushing it a little bit more. So I think right now what happens is I'll usually start someone on the Alter G probably like at the latter end of 4 months. And they'll be on an Alter G progression for about like 4 weeks, I would say, like generally gradually increasing their weight. So I think by the time they get on a treadmill, they're usually at like the end of 5 months or beginning of
Five,
six.
six.
Yeah,
Yeah.
they've gone to that.
Yeah.
So I used to start like Alter G at 6 months and then go later, but that's usually my progression now. But again, it all depends. Do you have your strength? So this is all
Yeah.
dependent on do you have strength? Like I'm very confident if you're at 5 months, you don't have your strength, I'm not going to put you on a running program. That's just a
Right.
recipe for disaster. So part of it is, are you doing the things that you need to do to get your strength back? And with cartilage patients, I'm very well with all my patients, but with cartilage patients a lot, I say I'm like, you're coming to see me twice a week for like an hour. That's nothing. I'm just teaching you what to do. You need to be putting your efforts into this rehab. And that means like if you're someone who doesn't have a gym membership, well, you better get a gym membership because you're gonna have to do some lifting and strength training outside of what we're doing. And at our clinic, we have strength trainers. So I'll
Yeah.
say at a certain point, I'm like, hey, have you hooked up with one of our strength trainers? Because you should, because you need to develop a strengthening program. You know those patients that are like, "Oh, I do a strengthening program. It's your rehab exercises." I'm like, that's not strengthening. That's rehab exercises. Like that's not doing anything. You need
It's the
some real.
furthest thing from,
Yeah,
yeah,
it's not.
yeah.
Like it's not what it is. So, you know, I really do take a lot of time in educating these patients in this patient population that hey, it's not me. I'm just providing you a roadmap of what to do. And I read Kyle's last IG post about meet what was it, meet LeBron's
Yeah.
preferred trainer and
We wanted
stuff.
to introduce us to the person LeBron trusts
Yeah, and
for his
for his
rehab.
Who,
rehab.
what
And
was that? Who was that?
It was I did not disclose in my post who that
I
was.
I didn't know who was
Oh, it's
either.
the one who you told me was.
It's the email that I got the other
Yeah.
day.
Oh, yeah,
Yeah.
It,
liars.
like the
Yeah.
thing with that, and we talk about it on our podcast all the time. I'm not giving any athlete the God-given talent that they have to play their sport. Like I'm not doing
Right.
that. So when I'm like, oh, when someone comes around, they're like, oh, I got so and so back to playing, or I got so and so. It's like, no, you didn't. This person knows
Yeah,
how to play basketball. You just
yeah,
help them with a particular problem. You didn't get them. You didn't show them how to pitch a ball. You didn't show them how to
Right.
dunk or shoot. Like you're there as like their roadmap person. It's them. They're the ones who did it. So, with these patients, I really tell them, I'm like, it's you who are doing it. So even when you go upstairs and you tell Dr. Williams or tell whatever, oh, like Snay got me back to where I need. Snay's just there to yell at you and kind of tell you what
guide
to
you through the
do.
process.
Yeah,
Yeah.
you're the
Yeah.
one who has to do everything. So it is especially a huge thing with cartilage patients where it's like, listen, this is a lot. This isn't easy. Not everyone is a cartilage patient. Like it's a special group of people that progress through here and kind of get to the point that they need to, but it's not everybody. Not everybody can do it. And so you gotta like educate this patient population that you need to be the ones that do this.
When are you looking at return to play?
Depending on the sport, I mean, we had a our best cartilage. I don't want to even call it the best. It's like the most extensive cartilage procedure I think that we did on a player. He was back at the 10-month mark at full competitive play. He did phenomenal. Uh, but again, it was him.
A lot of
He
factors.
did
Yeah.
a lot of the work that he
Mhm.
needed to do. So, returning, I'll get on my soapbox a little bit here. So I think
Yeah.
returning to play and returning to sports and competition are two different things. Like
Yeah.
returning to play is, hey, I'm just getting into practice or I'm getting some reps. And
Yeah.
sometimes when we read studies and they're like, oh, the return to play rate was 98%, and it's like, well, what does that mean? Did this person
Mhm.
Yeah.
just shoot a ball?
Yeah.
Like my thing is like I'm not worried about return to play. I'm worried about return to performance. Like
Yeah.
that's what it really means. It's not getting back into practice. Getting back into practice and returning to, play is that first step. That's why I always say like I never call our assessments return to play assessments. I call them return to sport assessments. That's what you're trying to get back to, high level sports. So it's kind of like, you guys have seen it. It's like, oh, hey, I'm 7 or 8 months out. I just passed all my metrics. I got all my strength and everything back. well, there's a tournament on Saturday. Like I can go play in that, right? And it's like, no, you can't go play in that.
Yeah, no.
You're completely
Uh,
unfit. And
You
so,
can do free throws.
yeah, it's like you're getting back into athletic activity. But returning to sport is a whole different thing. And I think a lot of times, as therapists, we forget about that. And, we're like, oh yeah, we're done. This person got back. But as the medical profession in general, it's like there's a whole different aspect to get back into high level sport. Like, I am a big proponent of, if you don't have a good strength and conditioning specialist you work with, or trainer that you work with, find one. Find one that's
Mhm.
close by, make a relationship with them, send your patients to them who actually want to return to high level sport. Because if you discharge them from formal physical therapy and they're not doing that second part, you failed at this. They're not going to get
Yeah,
back. So
yeah,
it's a huge aspect that I try to tell people. I do tell people, I'm like, if you're with me for 6 or 7 months, there's no effusion in your knee. It's moving around great. Strength you may still be a little bit weak, but strength looks good. Why are you with me? What am I
yeah.
providing you? I'm not. Are you coming here because, I'm
Psychological at that point, right?
yeah, it's like, listen, I'm providing no skill for you at this point. You need to either step it up on your home workouts, or you need to get someone to help you get to that later phase. And so over the years, my relationships with strength and conditioning specialists, like I said, we have two great ones in our clinic that, I use on a daily basis. I'm like, you want to get to the next level of sports, you need to see them. If you don't, that's cool. Not a big deal. I think on the pro level, they have that. You go back to a
They
team, they
have that,
have
yeah,
their
for
training
sure.
staff, they can do that. When you look at the regular person, they're like, oh, well, hey, Snay, my insurance pays for you. So I like to come here more. I'm like, well, I'm not providing a service for you anymore. So I think, as far as like the profession in general, we just have to do a better job of branching out and reaching out to those other people. Yeah, it means that you're going to have to discharge a patient. But I think it's necessary to get them to the level they need to get to.
I
I
think
love
that
that, finding someone in the community to help them, because
yeah.
we had that same issue where we weren't afforded early on strength coaches, but man, there was plenty of trainers or strength coaches that would gladly take our guys and work with them. And so they even set up like a special gym membership for them where they could come in for a short amount of time. And it's like, yeah, these guys they're gonna really take a lot of good care of you and do a lot more than I can do with my 7 other patients that I have going
It,
right now. So
exactly.
yeah,
Like, we only have limited time. And if I got
yeah,
like a cartilage patient that's a week out and you're 8 months out, like killing it, hey,
yeah,
I got to spend more time with this person that's a week out, because they're where you were. You
yeah.
can move on to getting into those latter phases at this time. But to bring it kind of full circle, like, it is very feasible, like very, very feasible, for cartilage patients to get back to high level activity. Like, I think
Yeah.
before, when they would do it, it's like, just plug this up. Let's hope for the best. Let's put the person out of pain, but don't ask us if you want to do anything, because
Yeah.
we're not in that. Whereas now it's totally changed. I think the population has changed in general. Like, it's very normal for you to see like a 60, 70-year-old be like, yeah, I'm still going to the gym 4 days a week, and I'm strength training, or I'm running. Like, this is a normal thing that you see nowadays.
Well, in just a short amount of time from when I was hot and heavy in the clinic, seeing the aggression that you guys are using with rehab, which is beautiful, is, it went from a salvage procedure, like we're just going to do this so maybe you can not hurt when you walk, to, yeah, you know what, we're going to weight bear you. There's no limits on your range. We're going to go after early strength with this BFR thing. And you have potential to get to the next level if you put in all the work. So
Yeah, yeah,
yeah, it's
yeah,
badass to see where it is.
yeah. We
And it's not
we
a cheap surgery. So,
yeah,
to see that it actually is getting people to higher level function is
yeah.
great.
And there's a lot of new things on the horizon for this. They have they're going to start, which they've already started. They've started to do, focoplasties as well. So sometimes for these bigger cartilage lesions that we've seen, that, you know cartilage, as with anything else, dies down after time. Like it degrades,
Mhm.
like that's just a normal part of things happening. And sometimes we've seen even these bigger cartilage grafts on people like, 10, 12 years down the line start to degrade. So it's like, okay, well, what are we doing for this patient population? Like they're older. Are we giving them a unilateral knee at this point? Well, they're not that old. What are we doing? So there's a new procedure of focal plasty that's come out where it's basically a titanium based osteochondral allograft. So it's titanium on one side and uh, bone interface on the other. So it basically acts like an osteochondral allograft, putting it into the lesion and bone growing into it. But you kind of have
Mm.
a titanium plug that's in there, which is much more durable at this point. You've saved yourself getting a total
A uni.
unilateral knee at that point,
Yeah.
but you're helping these patients again function to their highest level that they can, which it's just the population. That's how we're going. People want to function. Peter
Yeah.
T is great. He throws his stuff out here and says, "Hey, we're gonna live till we're 100," and everybody wants to do that. So procedures like this are, out there, and if you see it and you're a therapist and you see it, don't be freaked out. Like, what's going on here? I've never seen it. I think it's okay to, if you haven't seen a lot of these, to be a little bit more conservative on it, just to make sure you're doing the right thing. But you know, like with what you said, it's hard. It's nice to see that you're aggressive. Like I said, we're more permissive with what we let
Yeah.
these patients
Yeah.
do,
Yeah. It's
which is
better.
nice for them and nice for us.
Well, dude.
That's why we wanted to have you on, honestly, Snake, because like John and I were talking. I'm like, I feel like I hear a lot of people talk like they see a lot of cartilage,
That's,
and
that's a lot of
honestly, like we didn't in our clinic, and I knew Johnny had seen a decent
Yeah.
amount, but Johnny was even like, yeah, because even what we saw wasn't that much.
I,
So to
I,
Yeah.
hear somebody that's actually seeing a volume of these, I think is
When you
hugely
talk to like the Twin City
beneficial.
folks and what Snay's doing, I mean, there's these centers where you're like, yeah, I need to reach out to these folks.
yeah. it's
Yeah.
it's funny because I think when people call me, I- I'm a little bit too nonchalant when they call and they're like, I have this patient. I'm struggling with this, and I'm like, yeah, hey, no big deal. Don't sweat it. It's normal. And people
Yeah.
are like, really? Like you're very worried about this at all. I'm like, no, no, like not all of our cartilage patients get seen by us. They come from all over. So they go to different clinics and they're seen other places. And I'll get some freak out calls that are like, oh my God, the knee is swelling up. We don't know what to do. It's like, okay, it's okay. Like it's probably a bad knee. Like, step back a little bit. Did you do the anti-inflammatories? Are you deloading it? And sometimes, hey, these are bad knees.
How hard are you pushing your flexion?
Yeah.
That's part of it too. I mean, my intern's
Yeah,
like,
it's like,
his knee keeps blowing up, and he's just like cranking on. I'm like, stop, man, let it come, let
or
it come.
or they're walking around in this flex knee gait pattern. They're like, it's not
Yeah, yeah,
the edema staying. I'm like, well, they're walking with. I've had it really easily happen where they'll be like, well, we just need them to see you like one day. We don't know what's going on. And patient walk in and I'm like, is that how you walk? They're like, yeah. I'm like, does your knee straighten out? They're like, no. I'm like, okay, well, that's it. Like, I got nothing
this
else
is
for you.
here we go.
That's it. And so it's a short visit, and I'm like,
Boom.
Yeah,
and then you go upstairs. It's like, hey, yeah, this guy figured it out. He can't straighten out his knees, so that's it. They're like that was it. I'm like, yeah, that's it. He can't straighten out his knees, so it's gonna stay swollen. He's got no patellar mobility, so this may be more extensive rehab, or unfortunately, with some of these cartilage patients, like, well, maybe we need to do another procedure. Maybe we need to do a synovectomy.
yeah,
Maybe we need
yeah.
to do a release to get them over this hump. So, like I said, the cartilage patient, it's a special patient that, sometimes they get knocked around and they have to do a little bit more than what they want to get to their end result. And thanks for calling. Like I like that. I like the Instagram experts that are out there. I love those. I love reading them. Just to be like, what's that? I
Uh,
never seen people do
Well, now
that
that
at
we
all.
know you talk to
yeah.
people, I think, I wanted to throw out that we're going to put your cell phone number up for anyone
Please,
with a cartilage
please,
patient at
yeah.
the end.
If you did
Just
that,
call Snay if you have a cartilage.
if you did that, there would be a line of people outside your house bed. Like I would line people out there like, hey, I got your name from this dude, and he said that you could help me. That just be all over the place. Tit for tat, tit for tat.
Love it.
But more importantly, man, I want to plug. You guys have the Sports Rehab Lab podcast.
We started
And
the Sports
so
Rehab Lab last
you have your
about
own
2 years ago.
podcast?
Yeah, and really,
Okay.
what it is we do a podcast to educate therapists that are out there. We're just trying to put out information that we've known throughout the years, things we've struggled with, things that we do with procedures. And it's really just to show everybody like, hey, everybody can see these patient populations. Here's how we do it. Don't struggle through the struggles that we made. And just trying to put a platform out there for young clinicians, old clinicians to kind of know that, hey, it's not we're doing simple things, and we want you guys to be experts in the field too, and this is how we've done it. And it's more for education. We want people to learn the way we've learned. We want people to know what we know. We want them to ask questions to us, so we try to have as good of a time as we can on it. It's not for everyone that listens to it, we're not like the super nerdy guys who are like pulling out research all around the place. We're clinicians, and we've been in the clinic,
Real
and we know
world.
what works,
Yeah.
and that we can tell you that real world experience that we've had, and we what struggles we've gone through, and questions that you have. And we really want it to be that the profession continues to grow. We don't want to see this burnout rate where it's like our profession is like a bunch of old heads like me talking, and telling you what to do. We want these
Good,
young
man.
clinicians to say like, hey, yeah, hey, these guys were able to do it. They were able to advance their career. Here's how they did it. Here's the things they see. We can see this. And, we're just trying to push some of that stuff out.
Sweet, man. Well, we'll put a link in there. I've listened to some of them. They're good, man. So I think any therapist out there should check these things out. You guys got a wealth of knowledge, so it's good,
now
good
now
stuff,
that I've
man.
been on your podcast, like it's like an inherent thing that you guys have to get on ours. So
Tit for
Dude,
tat.
you've been talking about me being on
I-
there for like a year now.
I know.
I gave up.
But
dude.
we don't.
Back in the day, I used to be this new cool thing. Now everybody does it.
It's mostly us, man. Where it's like, it's like, all right, when are we gonna have these things? You should see us. Like sometimes we'll be like, all right, we'll record this thing. It's like, when are we recording this week? 6 a.m. We're gonna do this as a 6 a.m.
Yeah.
podcast on a Saturday. It's like, all right, that's when we do it. So,
Tough.
yeah,
These things are
exactly.
hard. People don't realize these are a lot more work than
Yeah.
they
Yeah, it is.
than they know.
Yeah, but it's fulfilling.
Doing this is the easy part. Then you got to edit it and put
yeah,
everything out. But yeah.
So yeah,
Cool.
but all good stuff. All good stuff coming on the horizon for us, So
Nice.
yeah,
Awesome.
yeah.
Well, brother, thanks for being on. I need to get
Thank
back
you.
up there and hang out, see your new clinic.
You guys are always welcome whenever
congrats
you
on
guys are in New
everything.
York. Yeah, come and
Yeah.
see us, whenever
Love
you guys are there. And yeah, we'll try to be very good hosts while you're here as well. So as best as
You
we
always
can.
are, man.
Look at
My
Kyle.
man.
Kyle's like, yeah, we're gonna go out somewhere. I can't wait. It's just
Kyle's like, well, it's time for
Alright.
another beer. What time is it?
I already-
4:35.
I already know.
Kyle, you're still on the clock, bitch. You owe me some money for all
No,
this.
I'm not at 6:30.
Oh, good times.
All right,
good
Snay.
times. All right,
Take
man.
care, brother.
All right, thanks, guys.
Take care,
Talk to y'all
Snay.
later.
All right, bye.
All right. Bye.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.
One last thing before we get out of here. First, want to say a sincere thank you for listening all the way through, but also wanted to remind you that this podcast should not be considered medical advice. It is strictly entertainment. It's a way for us to try to keep up with what is ongoing within the BFR world. If you require some sort of medical attention, medical advice, please seek that from a licensed individual within your state. Thanks, and we'll talk to you soon.